Hey beautiful future nurses, welcome back to Scrub and Spoon. Nurse Funke here, as you can see on my necklace. How are you all doing? Thanks for your support on all platforms. Okay, let's go right into it. And before I go, please don't forget to check out my website for the 11 body system master message flashcards. And it consists of over 120 Nclex most tested disorders. Okay, now today's Nclex review, we're talking about type 1 diabetes, type 2 diabetes. We're talking about insulin and oral anti-diabetic medication, which I know most nursing students don't know about. Okay, so stay tuned, watch till the end, subscribe, like, and comment. Okay, thank you. Now, without wasting our time, let's go right into the first question. Which statement by a patient starting glipizide requires immediate correction? A, I'll take it 30 minutes before breakfast. B, if I skip breakfast, I'll skip the dose. C, I can spend a lot of time outside. This drug won't affect my skin. Now, D, I'll check for shakiness and sweating as sign of low sugar. What's your answer? Now, guys, the right answer is C, I can spend a lot of time outside. This drug won't affect my skin. Let me explain it to you. Let's look at the medication they are taking. They are taking glipizide, which is oral anti-diabetic medication. And the mechanism of action of glipizide it increased insulin release from the pancreas. Okay, so if they should make which of the statements, if they should make the statement, you have to correct them. The patient says, I can spend a lot of time outside, the drugs won't affect my skin. That is a lie, because one of the side effects of glipizide is photosensitivity. That is when they are in the sun can affect their skin. They can get sunburn, they can get rashes, they can get itchiness in the sun. So side effects of glipizide is photosensitivity. So that statement need immediate correction. You have to correct them. They should be careful going outside and know the amount and minimize the amount of time they spend in the sun. That if they need to go out, they must wear sunscreen. They must wear protective clothing, and they should avoid prolonged sun exposure. So saying it won't affect my skin is unsafe and incorrect. Okay, I hope you understand that now. Now the rest of the statements are correct. I'll take 30 minutes before breakfast. Absolutely right. B, if I skip breakfast, I'll skip the dose. Yes, because if they do not eat and they take the medication, they risk hypoglycemia, because glipizide increased insulin release from the pancreas. Now, they didn't eat, but they've taken the medication. Insulin is released. There is no food or glucose to send into the cell. Now, the insulin starts working on the remaining sugar in their blood and send it into the cell. Now, there's no sugar in the blood at all, because at least there must be some level of sugar in the blood. It must be moderate level of sugar in the blood, because when there's too much sugar in the blood, that's when there's hyperglycemia, and then when there's low sugar in the blood, that's hypoglycemia. So now this insulin they didn't eat, this insulin start working on the remaining sugar in their blood and send it into the cell. Now there's no sugar in the blood, they become hypoglycemic, and that's why if they skip lunch, what does it say? If they skip breakfast, they should skip the dose. Okay, now C is our right answer, and D, I'll check for shakiness and sweating as signs of low sugar. Absolutely. So these statements, the remaining statements are correct. Now let's move on. The nurse teaches about Repaglinide. Which statement should be included? Select all that apply. A, it's taken right before meals. B, if you miss a meal, still take the dose. C, it's mainly blunt post-meal glucose spikes. And D, it has long duration like glucagon. E, it can cause hypoglycemia if you don't eat. Since it's selected or apply, let's go through it together as true or false. Okay, first off, before we do it together, let's talk about the medication. Repaglinide is also oral anti-diabetic medication, that is anti-hyperglycemic agents, and they help to lower blood glucose. Okay, now that you know, let's go through it. A, it's taken right before meals. Absolutely. Repaglinide is a mealtime insulin secretagogue. So yes, it's taken right before meals. Okay. Now B says if you miss a meal, still take the dose. No, your patient risk hypoglycemia, because if this medication helps to squeeze out insulin from the pancreas, insulin is released, there is no food. Hypoglycemia. Okay, so that's wrong. C, it's mainly blunt. C, it's mainly blunt post-meal glucose spikes. Repaglinide is short-acting, and it's mainly to control after-meal hyperglycemia. So this statement is right. Okay. D says it has a long duration like glucagon. Repaglinide is short and rapid-acting oral antidiabetic, so it is not long-acting. So it's not like glucagon. Glucagon is long-acting insulin that have no peak time. So that statement is wrong. And the very last one says E, it can cause hypoglycemia if you don't eat. Absolutely, I just explained it to you. I explained the mechanism of action of the medication. If you do not eat, it will cause hypoglycemia. So let's move on. Now the next question says, which insulin has the highest risk of hypoglycemia within 4 to 6 hours after dosing? A, Lispro, B, regular, C, NPH, and D, glargine. Now the right answer is C, NPH. Now, for you to know, see the question, highest risk of hypoglycemia. They are asking you about the peak time of insulin, because the peak time for NPH is between 4 to 12 hours, and this falls within this time, 4 to 6 hours. Okay, so the right answer is NPH. That's the peak time. And what's the peak time? This is the time insulin works the strongest, the time insulin puts all hands on deck to lower that blood glucose, and this is when your patient is at the highest risk of hypoglycemia. They need to eat, and that's what the question is asking you. And also for NPH, which is intermediate acting insulin, right? It is given once in the morning, twice a day, once in the morning, once in the evening, okay? And the onset of action is between 1 to 2 hours. The peak time is between 4 to 12 hours, and the duration is between 12 to 8 hours. So this is the only insulin within the strong peak time of the number given to us, 4 to 6 hours. Let's go through the wrong ones. A says Lispro, no, which is rapid acting, no. The onset of action for Lispro, I'm going to break everything down to you guys. The onset of action for Lispro is between 10 to 15 minutes. The peak time is between 30 to 90 minutes. And the duration, that is how long it stays in the body, is between 3 to 5 hours. So you see, that's wrong. Now, let's go to B says regular insulin, which is the short-acting insulin, right? Now, the onset of action for regular is between 30 to 60 minutes, okay? The peak time is between 2 to 5 hours. You see, that peak time doesn't fall within the number we were given. 4 to 6 hours is what we're giving. This is 2 to 5 hours. That's the peak time for regular, okay? And the duration is between 5 to 8 hours, okay? And C is our right answer. So D, glargine. Glargine is long-acting insulin. It has no peak time, and the onset of action is between 1 to 2 hours. It is steady release, no peak time for glargine, and that's why our answer is C. Let's move on. Which are correct about mixing and administering insulin? Select all that apply. A, draw clear before cloudy. B, mix glargine with NPH to reduce injections. C, rotate sites to prevent lipohypertrophy. And D, prefill mixed syringes and store for 30 days at room temperature. And E, verify dose with another RN for high alerts. What is your answer? Since it's select all apply, we'll go through it together as true or false, okay? Now, they are just asking us about insulin administration. Now, let's go. A says, draw clear before cloudy. Absolutely. And which one is clear? Which one is cloudy? In this situation, you are mixing regular with NPH, okay? So you are mixing regular, which is the clear, before NPH, which is the cloudy. That's how clear before cloudy in the same syringe. So you are drawing the clear before cloudy in the same syringe, okay? Now, B says mix glargine with NPH. Never you mix long-acting insulin. It's always alone. Never mix it with any other insulin. They are always lonely alone, because they have unique pH formulations, and mixing them with any other insulin alters their absorption, and it is unsafe. So never mix them. Now let's go. C, rotate sites to prevent lipohypertrophy. Absolutely. Lipohypertrophy is fat lumps under the skin from repeated injection at the same site. That's lipohypertrophy, and this will interfere with the insulin absorption. That's why they'll tell you to rotate the site within the same region, abdomen, for consistent absorption. So C is also correct. Now D says pre-filled mixed syringes and store for 30 days at room temperature. Now, mixed insulin syringes can be pre-filled, but they must be stored in the refrigerator. The question says store for 30 days at room temperature. No, they must be stored in the refrigerator. Unopened vials or pens can be stored at room temperature, not pre-mixed syringes, okay? So that is wrong. And E says verify dose with another RN. Absolutely right. Insulin is high alert medication, so you want to verify the dose with another RN, okay? So our right answer is ACE. Let's move on. A T1DM, that is type 1 diabetes mellitus patient, presents with Cosmo respiration, fruity breath, and blood glucose of 520. Potassium is 5.5. Blood pressure is 90/58. What is the priority initial order? A, IV insulin bolus. B, 0.9 normal saline bolus. C, sodium bicarbonate IV. And D, IM glucagon. So guys, you can pause this anytime to choose your answer before listening to the explanation if I'm going too fast, okay? Now guys, the right answer is B, 0.9 normal saline bolus. Now, hold up, let me explain it. Okay, see what's going on here. Your patient, they have respiration. Just like now, you have to look at the signs and symptoms given to you to know what's going on. Respiration, fruity breath, blood glucose is 520, potassium is 5.5, and blood pressure is 90/58. What do you think is going on here? DKA, diabetes ketoacidosis. Okay, that's what's going on. And our priority in diabetes ketoacidosis is fluid volume resuscitation to prevent circulatory collapse, because in DKA they are dehydrated because of what? Osmotic diuresis. And what is that? Peeing a lot, because the kidney is saying, okay, there's so much sugar in the blood. Look, 520. How can I help how can I help the body to get rid of some sugar in the blood? Okay, if I cause the body to pee a lot, they will urinate some glucose out with the urine, and then the kidney start to make the body to lose fluid through urination in order to lose some glucose with it, some sugar in the blood with it. Okay, and that's how dehydration comes in DKA. So they are super dehydrated, which can lead to circulatory collapse. So fluid volume resuscitation is our priority in DKA, and that's why we're going to for 0.9 normal saline bolus to restart the circulation. Okay, if fluid resuscitation is not dealt with immediately, look at their blood pressure. So their blood pressure is already low. What do they risk? They risk hypovolumic shock, and that's why we need to deal with the circulatory volume first before blood glucose. Because I made a video talking about treatment for DKA, FIC, fluids, insulin, and potassium monitoring. Okay, good. Now, so that's why we're using 0.9 normal saline, because 0.9 normal saline will help to restore perfusion, because all those signs are showing, especially for the blood pressure, hypotension, low perfusion, and it will help to stabilize the circulation. So that's why we're using 0.9 normal saline. Okay, now let's go to the wrong ones. IV insulin bolus, not first. And also, as once you give the 0.9 normal saline, then you can start insulin therapy, okay, to lower that blood glucose. It says IV insulin bolus. Absolutely, you might be tempted to go for that because the blood sugar is high, but it's not the first thing. Yes, insulin is needed. It's very important in DKA because it helps to stop the ketones production. But if you start insulin before correcting the severe dehydration and low blood pressure, guess what you risk? Shock. Hypovolumic shock. Okay? Also, insulin drives potassium into the cell. That's why the mnemonic for DKA, to remember treatment for DKA, is FIC, fluids, which is 0.9 normal saline, insulin, and K, potassium monitoring. Insulin drives potassium into the cell. The patient risk, if you start with insulin immediately, risk hypokalemia. So even though the patient potassium is 5.5, normal potassium 3.5 to 5. If you start insulin first, the patient risk hypokalemia later. So fluid is the first thing, okay? And C says sodium bicarbonate IV. Now listen to this. Acidosis is expected in DKA, and that is why the body is compensating with the respiration. And sodium bicarbonate, bicarbs, are almost never used unless the pH is less than 6.9. That is in severe life-threatening acidosis. And giving it too early can cause hypokalemia, okay? So it's not the priority. And D says IM glucagon. If you've seen my video, go watch it. I talk about oral antidiabetic medication. I also talk about insulin, the 4 types of insulin, the peak time, the onset, the peak time, and the duration. Glucagon is used to raise blood glucose in patients that are unconscious, nothing by mouth, or patients that are nothing by mouth. Okay, glucagon is used to spike up or raise blood glucose. So it is hyperglycemic agent. And their blood glucose, what we are trying to do here is lower the blood glucose. So why will you give them extra glucose, extra sugar? So that's why glucagon is so wrong. And the next question says, which finding best differentiates HHS from DKA? A, serum osmolality low. B, atrial pH is less than 7.2. C, minimal absent ketones. And D, blood glucose less than 30 mg/dL. What is your answer? Guys, the right answer is there. C, minimal absent ketones. What this question is asking is that Which of these signs or symptoms, when you see it, you know that, oh, this is HHS and not DKA. And in HHS, there's absolutely minimal or absence of ketones. You will see ketones in DKA, but in HHS, no. Okay, so that is differentiating it. And HHS is usually in type 2 diabetes. I hope you know that. Because in HHS, there is just enough insulin to prevent lipolysis/ketone production, but the insulin is not enough to lower the blood glucose. And that is why in HHS, there is barely or no ketones. This will differentiate DKA from HHS. Now let's go to the wrong one. A, serum osmolality low. In HHS, serum osmolality is actually very high due to extreme hyperglycemia, severe dehydration, and neurological changes. Okay, and B says atrial pH less than 7.2. This you'll find it in DKA, not in HHS. We are looking for signs that will tell you this is DKA. They will differentiate. We are looking for signs that will differentiate. That will tell you this is HHS. That will differentiate HHS from DKA. Okay, because in DKA, ketones will form. It will accumulate. That will lead to metabolic acidosis, leading to low pH. And in HHS, pH is usually normal. C is our answer, and D says blood glucose of less than 300. Very wrong. Now in DKA, the blood glucose is usually between 250 to 400 thereabout, while in HHS, higher blood glucose, severe hyperglycemia. So this one says blood glucose less than 300. Absolutely not. That is wrong. Okay. Now let's move on. A patient on Acarbose becomes diaphoretic and confused. FSBS, that is finger stick blood sugar, is 55. Which is the best treatment now? A, orange juice. B, peanut butter sandwich. C, glucose tablets. And D, chocolate milk. Guys, the right answer is C, glucose tablets. Now, you may not know about Acarbose. Acarbose is also oral anti-diabetic medication, that is anti-hyperglycemic agents, right? And there is a mnemonic you need to remember for Acarbose. Acarbose is against carb. Acarbose blocks the enzymes that breaks down carb in the gut. And so the right answer is C, glucose tablets. Because glucose tablets is pure dextrose and it can quickly be digested and absorbed directly into the bloodstream, bypassing the enzyme that Acarbose inhibits. And this will help to raise the patient blood glucose very fast. Now let's go to the wrong choices. Orange juice. Normally OJ, which is orange juice, works well because it has sugar, but the medication they took that is causing the hypoglycemia, the anti-diabetic medication they took, blocks carbohydrate digestion in the intestine, blocks carbohydrate digestion in the intestine. That means if you give them carb, if you give them orange juice, it's not going to digest to quickly correct the hypoglycemia or to quickly spike the blood glucose, because the signs and symptoms the patient is having is hypoglycemia. They are hypoglycemic. So if you give them the orange juice, it will not be digested to spike the blood glucose because of the mechanism of action of Acarbose, the medication they took that led to hypoglycemia, because the medication is to lower blood glucose. So I think it has done too well of its job. Now the patient is severe, now very hypoglycemic. Now B says peanut butter sandwich. This is mostly complex carb and fats, and it will not be digested to spike up the blood glucose, because we're looking for something you can take that will spike up the blood glucose when there's hypoglycemia. D says chocolate milk. Still the same thing. There will be slower digestion and absorption of this. Okay, so only glucose tab can absorb directly into the bloodstream. Only glucose tab can absorb directly into the bloodstream and bypass that enzymes that is inhibiting carb digestion. Let's move on. Before starting Pioglitazone, which findings would make the nurse question the prescription? Select all that apply. A, 2 pitting edema in ankles. B, ATL ×3 upper limit. C, history of NYHA class 3 heart failure. D, BMI of 29. Since it's selected that apply, let's go through it together. Now, before we go into the right answer, because we're doing it together, let me explain what's going on. Now, Pioglitazone, the medication they are taking, is also oral antidiabetic medication. And the mechanism of action is it decreases insulin resistance and glucose production. Now, this medication should not be given in patients with heart failure because it causes fluid retention. I think that will give you hints right there. So let's go through it together. Now, it says 2 pitting edema in ankles. Yes. Now, The doctor prescribed this medication, Pioglitazone. But when you want to give it to your patient, you see your patient have 2 plus pitting edema in ankles. What do you do? And you have to know that this medication the doctor prescribed also causes fluid retention. And 2 plus pitting edema is already showing that your patient is retaining fluids already. Fluid accumulation. So you don't want to give them medication that will cause more fluid retention. So you have to question this prescription. You have to question once you see, so you have to question the prescription, because once you see 2 pitting edema in ankles, you have to question that, oh, call the provider. My patients already have 2 pitting edema in ankles, which signifying they are already accumulating fluids, and this medication prescribed also causes fluid retention. What do we do? Okay. B, ALT 3 times upper limits. This is signifying elevated liver enzymes. And this medication, the class of this medication, they are toxic to the liver, hepatotoxicity. So you want to question that, okay, should I go ahead and give this medication? You have to question that and call the provider. Now, C, history of NYHA class 3 heart failure. Even if you don't know what NYHA is, heart failure is enough for you to understand what's going on. This medication is contraindicated. I just said it earlier that it's contraindicated in patients with heart failure, because in heart failure, fluid accumulation, edema can happen, and the patients already have heart failure, and the medication can cause fluid accumulation. That could be much accumulation of fluids in the lungs, because in left-sided heart failure, the signs and symptoms you will see will be associated to the lung sound, lung signs. Okay. So we question it in patients that already have heart failure. And D, BMI 29. Overweight or obesity is not contraindication in this medication. So even if your patient BMI is 29, you can still give this medication. So the ones you will question, the signs and symptoms you will see that will make you question this prescription will be A, B, C. A school nurse give IM glucagon to an unconscious patient with type 1 diabetes mellitus. Which action is most important immediately after injection? A, place the child in sideline position. B, give a protein shake. C, start a long-acting insulin. And D, apply a cold compress. Guys, the right answer is A, place the child in sideline position. You can always pause this to pick your answer before listening to my explanation, okay? And why is our answer A? Because glucagon often cause vomiting. And when you put them in sideline position, that will help to prevent aspiration in case the patient vomits, okay? And glucagon is used in unconscious patients that can't, that are NPO, okay? And this is given because they have low blood glucose. Look at the signs here. The patient is unconscious. Glucagon is given because the patient has severe hypoglycemia. This is used to spike up the blood glucose. Now, let's go to B. Give a protein shake. This is only appropriate when the child is awake and is able to swallow safely, okay? C. Start a long-acting insulin. Are you serious? Why are you giving insulin? They have hypoglycemia, and that's why we are giving them glucagon to spike up the blood glucose. They are already glucose because they are already even unconscious. Insulin will lower blood glucose, which could worsen the emergency. So we are not giving insulin here. We are trying to bring back the blood glucose. So severe that they are unconscious. So we are not giving insulin. And this says apply cold compress. This is irrelevant. It have nothing to do with the situation, the hypoglycemia. Okay, so this is wrong. So our right answer is A, place the child in sideline position to prevent aspiration should in case the patient vomits. Now let's go. Which teaching points are correct for patients on metformin? Select all that apply. A, take with meals to reduce stomach upset. B, report muscle pain or extreme fatigue. C, it commonly causes hypoglycemia when used alone. And D, stop the drug the day of IV contrast and 48 hours after. And E, it increases liver glucose production. So let's go through it as it's selected that apply. So we are looking for appropriate teaching when your patient is taking metformin. Now let's go. A, take with meals to reduce stomach upset. Absolutely. One of the side effects of metformin is GI upset. Okay, so yes, they should take it with meal to prevent GI upset. B, report muscle pain or extreme fatigue. Absolutely. This can be early signs of lactic acidosis in patients taking metformin. It is rare, but it's a life-threatening complication of metformin, lactic acidosis. C, it commonly causes hypoglycemia when used alone. Wrong. Metformin does not cause hypoglycemia on its own because it does not stimulate insulin production. Metformin lowers glucose production in the liver. and decrease intestine absorption of glucose. That's the mechanism of action of metformin. And it increases insulin sensitivity. So this one's saying it causes hypoglycemia. It doesn't. So C is wrong. Now D, stop the drug the day of IV contrast and 48 hours after. Absolutely, because IV contrast can worsen renal function. Metformin will accumulate and cause risk of lactic acidosis. This answer is right. Hold metformin on the day of contrast IV. Okay. Now E, it increased liver glucose production. Wrong. Metformin does the opposite. It actually decrease liver glucose production. That's the mechanism of action. Okay, so let's move on. So our answer is A, B, D. These are the correct teaching points for metformin. Okay, now let's move on. Now T1 diabetes mellitus adolescent on a continuous subcutaneous insulin infusion pump arrives with nausea and vomiting and abdominal pain. FSBS, that is finger stick blood sugar is 420. There is large urine ketones, which is the most likely cause. A, too much basal insulin. B, pump delivered intermediate acting insulin. C, infusion set dislodgement / occultation. And D, excess carbohydrate intake. And guys, the right answer is C, infusion set dislodgement / occultation. Let's see what's going on in this situation. With the signs and symptoms your patient is presented with, it shows they are in DKA, diabetes ketoacidosis. Look at their blood glucose, 420. Ketones is present, right? Why? So they're asking us, what is most likely cause of all these signs and symptoms? What is the most likely cause of this DKA? Given that they are on subcutaneous insulin infusion pump, they are on insulin infusion pump. And insulin infusion pump, the patient is able to adjust the dose, okay, as needed, per sliding scale as needed, right? Now, so the reason why, despite they're on infusion pump, insulin infusion pump, but they have DKA is because see, the pump is dislodged or occulated. So if the pump is kinked, blocked, disconnected, the pump will fail to deliver the insulin to the bloodstream. So this means despite they are on insulin infusion pump and they are able to adjust the dose, even when they are adjusting the dose, but because if the pump is disconnected, if it's kinked up, the line that's supposed to deliver the insulin is kinked up, occluded, that is blocked, the insulin will not be delivered to the body and they will risk hyperglycemia. That is why they are in DKA states, right? And that's exactly what is happening, okay? And this is most common cause of DKA in insulin pump user, blockage of the pump. Okay, now let's go through the wrong choices. Too much basal insulin. Look at the signs and symptoms your patient is presented with. Insulin will lower the blood glucose, but they have hyperglycemia. They are hyperglycemic, 420. So this is wrong, because if it's too much basal insulin, the blood glucose will be low. The blood glucose will be low. They will be hypoglycemic. Okay? And B, pump delivered intermediate acting insulin. No. Insulin pump only delivers rapid acting insulin, not intermediate acting insulin, which is NPH. Okay? C is our answer. And D, excess carbohydrate intake. Guys, yes, eating a lot of carb may raise your blood glucose. But look, there is ketones. Excessive carbohydrates eating or intake will not cause ketones. The patient have ketones, large ketones in the urine, according to the question. What does that tell you? So that's wrong. That makes that answer wrong, okay? Let's move on. Which patients have increased risk of hypoglycemia when prescribed Glyburide? Select order apply. A, an older adult with inconsistent meals. B, a patient who drinks alcohol at night. C, patient with sulfur allergy. D, patient training for marathon. And E, patients on propranolol, which is a beta blocker. Now, select order apply. All that apply. Let's go through it together. Now, we are looking for which patients will risk hypoglycemia when they are on Glyburide. Okay? Now, A, older adults with inconsistent meals. Yes, Glyburide is oral antidiabetic medication, and Glyburide increases insulin release from the pancreas. So if the older adult is with inconsistent meals, they will risk hypoglycemia, because if the patient take this medication and they skip meals or they are inconsistent with meal, and they take the medication will release insulin, and insulin will work on the remaining blood glucose, and they'll be hypoglycemic. Insulin will send the remaining blood glucose they have in the blood into the cell. Okay, so that is why that is right. B, patient who drinks alcohol at night. Absolutely. Alcohol can inhibit the conversion of non-carbohydrate substances like lactates into glucose, converting those substances that are not carbohydrates into glucose to maintain blood glucose. So alcohol can inhibit that, leading to a higher risk of hypoglycemia, especially taking alcohol overnight. Okay, you have to teach patients to avoid alcohol. Okay, so B, that patient will risk hypoglycemia. Now C, patient with sulfur allergy, wrong for hypoglycemia. Now sulfonylureas are chemical related to sulfur drugs. So sulfur allergy is a precaution, but it does not directly increase hypoglycemia risk. Okay, so that is wrong. Now D, a patient training for marathon. Absolutely. You know why? Because exercise increases glucose uptake combined with taking Glyburide. So exercise will take up a lot of glucose into the muscle, and so that means there is some there is some loss of glucose from the blood, right? And you are also taking Glyburide that will lower blood glucose. So double factor. This patient will be at risk of hypoglycemia. Okay? And E, patient on propranolol, which is beta blockers. And beta blockers mask the signs and symptoms of hypoglycemia, like shakiness, palpitation, tachycardia, those signs. Beta blockers will mask it, and you don't know they're already hypoglycemic. So if the patient is on propranolol, they risk hypoglycemia because you will not know that they already have low blood glucose, low blood sugar, because the medication they are taking will not let those signs show. So you will not know until they will get to severe hypoglycemia. Until they will get to severe hypoglycemia, you will not know. Okay? And if there is severe hypoglycemia, you know what to give: glucagon. So our right answer is A, B, D, and E. Let's move on. Which instruction is best when starting Acarbose? A, take it 2 hours after meals. B, take it with your first bite of food. C, take it at bedtime. And D, take it only if your glucose is above 200. And guys, the right answer is B, take it with your first bite of food. Okay? And why? Because Acarbose delays the digestion of complex carbohydrates in the small intestine. It inhibits the enzymes that break down carb in the gut. Okay, and that's why that answer is right. For Acarbose, B, take it with your first bite of food. Okay, let's go through the wrong choices. A, take it 2 hours after meal. I just said it, take it with your first bite of meal. Okay. C, take it at bedtime. Timing with meal is critical, not at bedtime. Okay. Now, and D, take it only if your glucose is above 200, not based on blood glucose reading. Okay, so the right answer is B. This instruction is the best when starting Acarbose. Take it with your first bite of meal or food. Okay, let's move on. And the very last one, guys, thank you for staying till the end. Thank you for watching till the end. Now let's go to the last one. For patients call the endocrine clinic, who should the nurse call back first? A, type 2 diabetes mellitus on Glyburide, report skipped lunch and now very shaky. B, type 1 diabetes mellitus, blood glucose 220 after a birthday party. C, type 2 diabetes mellitus starting metformin, has mild diarrhea. D, type 1 diabetes on glargine, says blood glucose is 160 before bed. Guys, the right answer is A. Look, the patient have, let me look at it. Type 2 diabetes, and they are on Glyburide. This is an oral antidiabetic medication, and they squeeze out insulin from the pancreas. And the patient report that they skipped their lunch and they are now very shaky. Shaky alone should give you signs of hypoglycemia, and they skip lunch, so they took insulin without food. Risk of hypoglycemia. So that's the first person the nurse should call back, because that patient is hypoglycemic, and that's why the signs of very shaky is there, right? Now let's go through the wrong ones. B, type 1 diabetes with blood glucose of 220 after a birthday party, mild hyperglycemia, and there is no signs or symptoms indicating very severe. So mild hyperglycemia, not immediately dangerous compared to someone that's shaky from hypoglycemia. Hypoglycemia kills faster than hyperglycemia. I hope you know that. Okay, So that is not the first person the nurse will call back. Now, see, type 2 diabetes starting metformin has mild diarrhea. This is expected side effect of metformin, and that's why they will say take it with food to prevent GI upsets. So this is not the nurse's immediate priority. And the last one is type 1 diabetes on glucagon, says their blood glucose is 160 before bed, slightly above target but not critical. You won't leave somebody that is having hypoglycemia, severe hypoglycemia, that they are very shaky, to attend to someone that is reporting 160 glucagon. And I hope you know that glucagon is a long-acting insulin. It works for 24 hours or more. So this is not your priority. The patient is not in immediate danger. Your priority is the patient that is in immediate danger, which is A. Okay? Thank you guys for watching. Bye.